Good morning, good afternoon and good evening. A very warm welcome to you all on behalf of the IAPB. We're very much looking forward to supporting you during today's IAPB COVID-19 and eye health series webinar, Blinded by Sugar.
Thank you, Debbie, and good morning, good afternoon and good evening to everyone, wherever you are in the world. Just by way of introductions, my name is Fabrizio, as Debbie said. I'm here today as the chair of the IAPB Diabetic Retinopathy Work Group. I'm also senior diabetic retinopathy and research advisor at the Fred Wallace Foundation. I'm based in Australia, and I advise the regional office of the Western Pacific of WHO on eye health. A bit of an overview on how this session will pan out today. First, we'll hear from Dr. James Muki, our keynote speaker, of course, and then we'll have two rounds of discussions with our panelists. And at the end of each round of discussions, Drew Keys, also from the IAPB, has kindly agreed to read out the questions from the audience. So I do strongly encourage you to write down questions as they pop into your mind while you're listening to the presentations and the panelists speaking. Debbie also mentioned we have some poll questions. So this is an opportunity for us to interact with you who are listening today. I'll be asking 3 questions throughout the sessions. They're not trick questions, they're just very simple questions. The first question I would like to ask now, if Debbie could pop it on the screen. So which of the following is a key risk factor for diabetic retinopathy? Is that a high fat diet, high blood sugar levels, or stress? Debbie, when you're ready, if you think we've got that. Yeah.
There you go.
Okay, so obviously very, very well-informed audience today. The key risk factor for diabetic retinopathy is high blood sugar level. Another key risk factor is high blood pressure, but that wasn't on the list. We do have a packed session, so I'm going to stop faffing about and I'll move right along. I'm sure you all know Dr. James Muki, who is our keynote speaker today. James is an ophthalmologist who has worked for 3 decades to prevent and treat blindness in some of the world's most complex settings. Among his many, many achievements, James started Vision Myanmar back in 2000. And then about 15 years ago, Sight for All, which is an NGO that now reaches around 1 million people with eye conditions around the world each year. In 2012, he was appointed a member of the Order of Australia. And then, of course, this year, he was appointed Australian of the Year. And it is in this capacity that James has been advocating for a stronger response for in the fight against diabetes and its complication. And so without further ado, I am going to throw it over to you, James, for your presentation.
Thank you very much, Fab, and thank you to Debbie and the IAPB team for making this possible. I really appreciate the opportunity, and particularly the opportunity to talk more deeply about diabetes. You know, we're working in the ophthalmic space and the visual space, so to have a deeper understanding of how this has all come about, I think it's really important. So I'll go ahead and share my screen now, and we will get started. Now, hopefully everyone can see that. As Fab mentioned, I started my ophthalmic training about 30 years ago. So for 30 years, I've been dealing with the consequences that diabetes inflicts on the eyes. In fact, every year, I'm seeing more and more patients who are losing vision, even going blind due to their diabetes, in particular type 2 diabetes, which makes up about 90% of cases and is a largely preventable dietary disease related to the consumption of too much sugar in our modern diet. But for me, things took a change in 2018 when I met a man whose story had a very, very powerful impact on me. His name is Neil Hansel, an everyday Australian who has a wife and 4 kids. He constructs light machinery for a living, and he also has type 2 diabetes. And a few years ago, at the age of 50, diabetes changed Neil's world forever. Unfortunately, he neglected his disease. He paid the price. He went to bed one evening with normal sight and woke up the next morning blind in both eyes. One of my retinal colleagues worked really hard to try and retrieve his sight, And unfortunately, it was too late. Neil was to spend the rest of his life in darkness. This is how Neil sees the world these days.
Basically, I think I would describe it as seeing everything as as emotion, not as an actual vision. The images, unfortunately, aren't clear. The images are basically what you see of a day through your eyes is what you see of a night through your eyes. So there's no clarity. I see black figures as people or animals or trees, just black onto a greyish background.
Neil lost his driving licence, he lost his independence, and he lost his ability to teach the javelin, which was his hobby. In fact, it was a passion that gave him incredible joy. But the thing that upsets Neil the most is that he can no longer see the beautiful smiles on the faces of his wife and his grandkids. This is a picture of Neil's wife and 2 of his grandkids. This is how he should see them, and this is the reality. Neil has been irreversibly blinded by sugar. And Neil is not alone. He is just one of over 100,000 Australians with sight-threatening eye disease due to diabetes, and I suspect one of quite literally millions of people around the world. So how does diabetes threaten the sight? Well, it causes damage to the blood vessels throughout the body, including the retina, the light-sensitive layer of tissue that lines the inside of the backs of our eyes. This is a picture of the central vision area, or the macula of a patient with type 2 diabetes. And this is that same eye a short time later. Diabetes can cause bleeding inside the eyes that can take away the eyesight in an instant and sometimes permanently. The important point here is that the vast majority of loss of vision and blindness due to diabetes is preventable or treatable, something like 98%. Yet to avoid the blinding consequences of this disease, people need to have their eyes checked on a regular basis. In Australia, as an example, of the 1.7 million people who have diabetes, well over half are not having their regular, all-important sight-saving eye checks. And that's why it's become such a serious blinding condition in our society. It's actually the leading cause of blindness amongst working-age adults in Australia, and I suspect also in many countries of the world. It's also the fastest growing cause of vision loss in many poorer communities. So for me, as an eye specialist, it upsets me to see people going needlessly blind due to their diabetes. But the thing that makes me really angry is that this disease should not be happening at all. Type 2 diabetes was a disease that was virtually non-existent in the 60s. These days in Australia, we see about 250 new cases every single day in a population of about 25 million people. So this evening, or this morning in some other parts of the world, I'm going to be talking to you about type 2 diabetes, how it's arisen, why it's a growing epidemic, and I'm going to look at some strategies to help curb this rising tide of a disease, which is a serious threat to our health system in each of our countries and to our society as a whole. So I talked about the fact that that type 2 diabetes is a largely preventable disease related to the consumption of too much sugar in our modern diet. So when one talks about sugar, we often think of table sugar, what we stir in our tea and coffee. But it's important to remember that there's another very abundant form of sugar, and this is the refined carbohydrates. So products such as white flour, white rice, white potatoes, and the foods made from these. These are what we call, these are basically all virtually pure starch, and starch is just simply long chains of glucose, which are broken down into single molecules of glucose when they reach the gut. So when you're ingesting refined carbohydrates such as these, you're pretty much ingesting pure sugar. And it's really important to remember that sugar and carbohydrates, in particular the refined carbohydrates, are nutrient poor and non-essential. There's not a biochemical process in our bodies that demands that we ingest sugar and carbohydrates. So going back to sucrose, so this is made up of 50% glucose and 50% fructose, so equal parts. But the body handles these two substances in completely different ways. So let's look at glucose first. When glucose is absorbed into the bloodstream, it triggers the release of the hormone insulin from the pancreas, and the insulin helps move the glucose into every cell of our body where it's either stored or used as an energy source. When I talk about glucose metabolism, I like to use the analogy of a subway train in Tokyo, where the train car is the cell, the passengers are the glucose molecules, and the conductor is the insulin. With prolonged and excessive glucose intake, the cell becomes full and the insulin level rises to try and push more glucose into the cell. But we reach a stage where we quite simply can't push any more glucose into the cell. This is when we become what's called insulin resistant. And then there's an overflow of glucose back into the bloodstream, and this is taken up by the liver and converted initially into glycogen, which is stored in the liver. But the glycogen stores are limited, and so what happens is that the liver starts turning the glucose into fat, which is exported away from the liver and stored in healthy fat cells throughout the body. It's actually a protective mechanism. When the production of fat by the liver outstrips its ability to be exported, the liver then starts to take on and store the fat itself, and we develop what's called a fatty liver. Now, I'm sure we all know what a normal healthy liver looks like. It's a deep dark red color. Well, this is a human fatty liver, and it's yellow because it's suffused with fat. Now, a great example of a fatty liver comes from the French culinary delicacy foie gras, which is created by force-feeding geese refined carbohydrates in the form of high-starch cornmeal. And a fatty liver can develop in these unsuspecting birds in 10 to 14 days. In humans with excessive fructose intake, we can develop a fatty liver within a couple of months. So let's look at fructose. So fructose is that molecule of table sugar, which gives sugary products their sweet flavor. It's not recognized as a food by the body. It doesn't trigger the release of insulin, and it actually suppresses our appetite control system. And when it's absorbed into the bloodstream, it 100% is taken up by the liver and metabolized by the liver, and about 30% is converted immediately into fat. So it's actually far more toxic than glucose and giving rise to a fatty liver. Now, this is a cross-section through a normal healthy liver, and you can see the densely packed cells. And this is a fatty liver. You can see it's distended, and those white spaces are cells which are full of fat. Now, type 2 diabetes can take on average about 13 years to develop after we develop fatty liver. In children, however, it can develop actually within 2 years. And it's a complex metabolic process, but what ultimately happens is that the liver becomes full of fat and can no longer store anymore. So the excess fat is exported away from the liver as triglyceride, and triglyceride is harmful to our bodies. The high triglyceride level in the blood combined with a high insulin level can give rise to the formation of fatty plaques, which then block the blood vessels throughout the body. And this in turn leads to the many life-changing and life-threatening complications of this disease. So we've talked about loss of vision and blindness. It can also give rise to impotence, numbness, pain, tingling in the hands and feet. And damage to the blood vessels in the brain can give rise to dementia. In fact, about 70% of patients with type 2 diabetes will ultimately develop dementia. And having lost a father to dementia, it shows you that this is a disease that impacts on the entire family, not just the individual. And damage to the fine blood vessels of the kidney can lead to kidney failure. And when the kidneys fail, the blood needs to be filtered artificially through dialysis, sometimes up to 7 hours a day, 4 days a week. In Australia, I've calculated about 4.5 million hours are spent patients with type 2 diabetes hooked up to a dialysis machine every single year. This is again for a population of 25 million people. So this is time lost to family and friends, to the things that they love to do, and also to their workplace. So blockage of the major blood vessels of the body can have devastating consequences. The second most feared complication of type 2 diabetes after loss of vision is gangrene of the lower limbs. And you can see here a patient who has type 2 diabetes and a gangrenous foot. So such a foot needs to be amputated. So type 2 diabetes is the leading cause of amputations in the world. And here is our friend Neil Hansel, who you met at the beginning. This is him in his hospital bed the day after his left leg was amputated in March this year for his gangrenous left foot and leg. In fact, Neil has had 9 amputations over a 14-month period. And this is after he went blind in both eyes. And Neil has also had 2 heart attacks. So this is also a deadly disease. In fact, 80% of patients with type 2 will die of a thrombotic complication, such as heart attack or stroke. Globally, it's the 7th biggest killer. But if we realize that type 2 diabetes plays an integral role in the causation of the top two killers, so heart attack and stroke, and it also plays a very important role in cancer, then perhaps it's actually the biggest killer in our midst globally. And so globally, our poor diet is responsible for more disease and death than inactivity, smoking, and alcohol combined. And if we look at the current pandemic, we're actually 12 times more likely to die from COVID-19 if we have type 2 diabetes. So this is something very important to be aware of, and for entire countries and health systems to be aware of. And it's also an incredibly expensive disease. Globally, 20% of the health expenditure is spent on diabetes, amounting to about $673 billion. Absolutely crazy when you think that this disease shouldn't even be happening in the first place. So how did this all come about? Well, humans are hardwired to love and seek out sweet things. It's an ancient survival mechanism that helped our ancestors survive extended periods of fasting, which were common in early humans. It also allowed them to avoid bitter and potentially poisonous foods in their environment. Prior to the 1600s, sugar was an expensive commodity. It was the domain of healers and holy men, and an indulgence that could only be afforded by the wealthy and powerful. Over the next 300 years, the rising availability and popularity of sugar due to the booming sugar trade led to diminishing costs, turning sugar from a luxury item to an everyday necessity. And these days, sugar is cheap, and sugar is quite literally everywhere in our lives, isn't it? But things took a turn for the worse in 1980 when the Dietary Guidelines for Americans was released. It was noted in the decades after World War II that there was a rise in heart attacks, and that this was thought to be due to a fatty diet giving rise to a fatty blockage of our coronary arteries. And so on no strong scientific evidence, the recommendation of the guidelines was to reduce our fat to 30% and to compensate for this to up our carbs to 60%. And rather than seeing a downturn in heart disease actually soared, and took along with it type 2 diabetes. And in fact, type 2 diabetes has risen fourfold globally over the past 40 years since these guidelines were released. And it's been more profound in some countries and communities. In China, for example, there's been more than a tenfold increase in type 2 diabetes since 1980. And this is somewhat paradoxical because the Chinese diet is high in white rice, a refined carbohydrate. But what we've noticed in Asia in recent years is the rising sugar consumption, which is amounting to about 5% a year. And this has been devastating to the Aboriginal people, the First Nation people of Australia. There's been an 80-fold increase in type 2 diabetes since 1980. And I have no doubt that a diet high in sugar, refined carbohydrates, and highly processed foods is driving this terrible, terrible situation. We also see type 2 diabetes in poorer socioeconomic areas. And just as an example, in Australia, Greater Western Sydney, you can see the red area is the area with the highest prevalence of type 2 diabetes. And in fact, 50% of adults over the age of 24 in Greater Western Sydney have type 2 diabetes or pre-diabetes for the first time in our history. And there's a similar situation in the United States. And also incredibly concerning is that we're seeing this disease now in children. This was a disease that used to be called maturity onset diabetes. And this is a global phenomenon. In 2001, less than 3% of all cases, new cases of diabetes was due to type 2 diabetes. In over a 10-year period, this has risen to nearly half. And there's also a very famous case of a 3-year-old child in the United Kingdom who had type 2 diabetes due to a diet high in sugary drinks. And there's actually children as young as 7 in Australia that we're seeing now with type 2. So what are we going to do about this? Well, if we're going to call it a dietary disease, then there should be a dietary cure. It should be as simple as reducing our intake of sugar, of refined carbohydrates, and highly processed foods. But there are a number of factors that make this a more difficult thing to achieve. And I came up with the concept of the 5 A's of sugar toxicity earlier in this year when I was getting my head around it as an ophthalmologist. And the 5 A's are addiction, alleviation, accessibility, addition, and advertising. And we'll go through those quickly in turn. So firstly, addiction. Sugar is highly addictive. It's been shown neuroscientifically to be as addictive as nicotine. Its consumption activates the reward center in our brains, leading to the release of the neurotransmitter dopamine. It's what makes us feel good. It's what makes us want to do it again. And it's what gives us those cravings. And like drugs, the more we ingest, the more we need to give us that feel-good hit. So it becomes a vicious cycle that's very hard to break. The second A is alleviation. We often use sugar to alleviate stress or to make us feel better when we're down. When we're stressed, the body is flooded with the stress hormone cortisol. So the brain needs to balance this up by releasing neurotransmitters from the feel-good centers, such as dopamine. And so sugar, as I've shown, does a very good job of that. Third A is accessibility. As I mentioned, sugar is everywhere in our lives. You can't walk into service stations, gas stations, without being confronted by a wall of confectionery. And you certainly can't check out of most supermarkets and stores in many parts of the world without being enticed by soft drinks and chocolates. In fact, a recent study in Australia showed that 90% of food at checkout counters of supermarkets and stores are junk food. And about 30% of these are on sale in any one week in our major supermarket chains in Australia. Fourth A is addition. An astronomical amount of sugar is added to our food and drink, something in the order of 75%. And finally, advertising. Our world is flooded with ads and TV commercials for sugary products, sometimes in the most insidious of ways. And this has been going on quite literally for decades. So any approach to this is going to have to also be able to deal with the 5 A's of sugar toxicity. So once again, let's look at these. So for addiction and alleviation, it's about awareness, being personally aware of how addictive sugar is and that we're using it to alleviate stress. And for the other 3 A's, it's about accountability of businesses, of industry, and of government to do the right thing by the people of the world. So let's look at these once again, each in turn. So firstly, addiction. Now, I suspect much of the world is addicted to sugar. I certainly was and probably still am. The thing I love the most is ice cream. The bigger the better. You know, the worst punishment I could receive as a child was to be sent to my bed after dinner without ice cream. But I received a bit of a shock this year when I had a scan of my liver, and I found out that I actually have a fatty liver. And in fact, here is a picture, an ultrasound of my liver, showing the early fatty liver changes. And for those of you who know me, I'm not overweight, I'm not obese, I'm what they call toffee, thin on the outside, fat on the inside. And this is a real danger sign. And interestingly, in the United States, and I suspect in Australia and many other parts of the world, there are actually more thin metabolically unhealthy people than there are fat metabolically unhealthy people. So this is something really important to be aware of. Second A is alleviation. You know, when we're stressed, rather than turning to sugary products, rather than reaching for that block of chocolate, why not take the healthier options? Go for a walk somewhere beautiful out in nature. Listen to your favorite musical playlist, or reach out to someone and do a good deed. These have all been shown neuroscientifically to be as effective as sugar in countering that cortisol reaction that's flooding the body during anxious times. Third A is accessibility, and there are a number of strategies that we can use here. You know, for example, removing sugary products from vending machines in hospitals and universities where they're in abundance here in Australia. Removing sugary products from checkout counters of supermarkets and stores where they're preying on our addictions, they're preying on the vulnerable, and they're preying on our children. And I was delighted to see in Berkeley, in California, they've actually banned candy sweets from supermarket checkout aisles. And this is a checkout counter in one of the supermarkets in my hometown where they've replaced sugary products with packets of nuts. So this is the sort of thing that I'd like to see everywhere. Fourth A is addition. I'm not sure how it is in the rest of the world, but in Australia, we have these nutritional labels on the packets of foods. I can barely read them, let alone understand them. And they certainly don't tell us the amount of added sugar contained within. We need to see a clear front of label system which transparently shows us how much added sugar is contained within the said products. And I'm delighted to see recently in Sri Lanka, they actually have already put in place a traffic light coding system for soft drinks and also doing the same now for highly processed foods. So this is something we need to see globally. And this is where the rather contentious issue of a tax on sugary products comes in, but there's certainly some good reasoning and solid evidence behind it. Sugary drink consumption has been definitely linked to type 2 diabetes in many, many studies. And a levy or a tax on sugary drinks has been shown to reduce purchase and reduce consumption now in 17 different countries. So it certainly makes sense for me. And the final thing is advertising. Again, a number of strategies that we can engage here. And one of the obvious things in Australia is the fact that on TV during those hours when our kids are watching television, there are often many ads for sugary products. So these really need to go. And there's also a huge amount of targeted advertising to children on social media. And I was delighted just today to see in the United Kingdom that they've banned online junk food advertising to try and tackle obesity. So there are a lot of good strategies being engaged in a number of countries around the world, but this needs to be a systemic approach, not just any one single strategy. And in Australia, removing sugary product ads from government buildings and services such as buses and trams would be a good idea. And we do need to see a far-reaching awareness strategy to comprehensively raise awareness amongst the public of the multitude of health dangers of excessive sugar consumption. But we also need to see some positive messages that type 2 diabetes is actually preventable. And in many people, it's also potentially reversible. This is something that's not known even amongst general practitioners. There are now 3 modalities that can put type 2 diabetes into remission: a very low calorie diet, a low carbohydrate diet, and bariatric surgery. And I'm a big advocate for a low carbohydrate diet. There's now over 100 controlled clinical trials to show that this can put type 2 diabetes into remission. And this is just one example where we saw a 56% reversal in a 10-week period in patients with type 2 on a low carb diet. And we need to stop demonizing natural saturated fats in our diet. This has been demonized, as I said before, on no scientific evidence, but products such as what you can see here on the screen, and also whole fat dairy, unprocessed meat, eggs, even dark chocolate have never been associated with an increased risk of cardiovascular disease. Critical information in our dietary guidelines need to be revised and reflect this. They, for too long, have demonized natural saturated fats to the detriment of our health. And we need to be encouraged to just eat real food, foods such as what you can see here, and avoid the packaged, labeled, and highly processed junk that we're consuming by the gallon. And we also need to see some hard-hitting commercials on television, for example, and on social media. And I created this ad for Sight for All a couple of years ago, which I'm going to play you now.
I should have kept my medication up, and I should have followed the plans that were given to me by my doctors. I woke up one morning completely blind. Thought I was dreaming, went back to sleep for an hour, woke up and I was still completely blocked off. My wife's face when we went to bed. That was the last clear image I had.
It's a heart-wrenching story, isn't it? Now, that ad played on one television channel in Australia a couple of years ago for about a 6-week period, but it played as what we call a community service announcement, so probably only played at 2 or 3 in the morning. But we need to see such ads across all television channels during primetime television and for extended periods. For me, it's all about education. You know, these days, would you leave a pack of cigarettes on the kitchen counter for your kids to enjoy? Absolutely not. So why would we leave a bowl of sugary treats? We need to exchange that bowl of sugary treats for a bowl of nuts, for example. We need to educate our kids, and yet we can't educate our kids until we know and understand ourselves as adults. How about those soft drinks in our fridge? Perhaps this is their gloomy future. Perhaps soft drinks, like smoking, we need to make socially unacceptable. Now, I'm just going to leave you with one last message from Neil Hansel from his hospital bed the day after his left leg was amputated.
I had a little joke the other day, and I put my hand up and I had a grain of sugar between my fingers, and I said, "Meet my killer." And people were trying to see what was in my fingers, and all it was 1 grain of salt, 1 grain of sugar. And that's what it takes. You know, we as a society, we have to do something. We've got to make people aware that the more sugar we intake, the worse this is going to get. And it's not good. It's not good.
No, it's not good, is it? As an eye specialist, I never want to see another patient going needlessly blind due to their diabetes. As a doctor, We should not be seeing the life-changing and life-threatening complications of a dietary disease that's largely preventable. And as a society, as a planet, I truly believe it's a time to put an end to type 2 diabetes. Thank you very, very much. I'm just going to play you show you one last slide. In fact, I might even copy those and put them in the chat line for any of you who want to follow Sight for All and the work we're doing, or for any of you who want to follow my journey this year as Australian of the Year. So I'll stop sharing my slide and we'll hand it back to the IAPB Dean. Thank you very much.
Thank you so much for your presentation, James. Very insightful. And I find Neil's story very, very powerful. I had seen the video before, and I think one of the things that really gets to me is when he talks about the realization that he had seen his wife essentially for the last time. Yeah, so that's quite powerful. And there was a couple of things that you brought up that really stood out to me. 4.5 million hours hooked up to dialysis machines. I just did a quick calculation. That's 513 years. That is just mind-blowing to me. And on the other side of things, I also made a note about the fact that dark chocolate is not going to give me an increased risk of cardiovascular disease.
Good to know.
There will be opportunities to hear questions from the audience soon. So I do encourage everyone to please post questions in the chat box. But I just want to move on quickly to another poll question, and then I'll introduce our panelists. So on average, how many people with diabetes do have diabetic retinopathy? Is it 1 in 3, 1 in 5, or 1 in 10? And Debbie, I'll leave it up to you when you think there's enough responses in there to please show the results. Yeah.
Share the results.
So interestingly, about 1 in 3 people with diabetes have DR. So well done to those of you that got that right. And 1 in 10 people with diabetes have a form of DR that is so severe that it threatens their vision. And I also want to point out that this data, even though it's widely accepted, it's from quite a few years ago now. And also it's not necessarily representative of what's happening everywhere. There's quite a lot of variability between low-income countries and high-income countries. But yes, 1 in 3 people with diabetes on average has DR. Anyway, moving on to our panel now. I am super happy with the panel that we've been able to convene, and I'm really grateful to all our panelists for joining us. I'll introduce everyone quickly, and then I'll get on with questions. I'm mindful of time as well. I'll start by introducing Michelle Silvanovitz. Michelle is the Director of Global Advocacy and Ophthalmology at Bayer Pharmaceuticals. And Michelle is really well entrenched within the international DR community. And over the last few years, Michelle has been instrumental in setting up the rollout of the DR barometer study. So thank you for joining us, Michelle. We've also got Dr. Fariza, who is the National Head of Ophthalmology Services in Malaysia. Dr. Fariza played a key role in setting up a tertiary centre for the very first medical retina services in the Ministry of Health of Malaysia. And she also established a formal training structure for retinal diseases, which has essentially transformed the unit into the largest medical retina centre in Malaysia. And last, but certainly not least, we've got Professor Thankapan from Central University of Kerala in India. Professor Thankapan is a Harvard graduate, and I'm sure he's not going to mind me saying he's one of the most prominent public health and NCD personalities in India. On a personal note, I've worked with Professor Thankapan closely when he was heading the Achuta Menon College of Medical Sciences in Kerala, which is part of one of the largest medical schools in the state, and it's one of a handful of institutes that are formally recognised as being of national importance in the country. And we worked closely on the rollout of a diabetes prevention program a few years back, and I'll be forever grateful for the example of leadership and mentorship that is demonstrated. And I will ask you the first question for the panel, Professor Thankapan. You obviously have expertise in diabetes and tobacco control. It seemed, I guess, a little bit like an impossible task. And yet my understanding is that most of the provisions relating to tobacco control in India have now been approved. Listening to James's presentation, I think the parallels there are obvious to me. And so my question to you is, what can the diabetes sector learn from the tobacco sector so that we can get on top of this epidemic?
Thank you, Fab. I think the number of people using tobacco in India in 2009-10, the Global Adult Tobacco Survey was 275 million. That is almost 10 times higher than the entire Australian population. And it has come down to 267 million after about 10 years, and 6-7 years, 2015-16 in the Global Adult Tobacco Survey too, which means the work that we have done on tobacco control was somewhat effective. About 7 million reduction in tobacco usage in India. It's not that a small number. But I think still we have a long way to go, because we were focusing on tobacco prevention, but then the activities on tobacco cessation, if you run parallel with the diabetes, for example, there are 2 activities for prevention: diabetes prevention, tobacco prevention. Tobacco prevention is preventing new people to uptake tobacco, for example, focusing on schools, colleges, younger population, while tobacco cessation is focusing on people who are already tobacco users, addicted to tobacco users, and we had been to stop them using tobacco. In fact, if you look at the tobacco cessation in India, it is very, very small. For example, we have only a handful, maybe less than 20 tobacco cessation clinics. The entire country of 130 million, 1.3 billion population. That is not enough at all. So we are focusing on actually tobacco prevention. For example, if I go back to the previous presentation, in fact, there were, for example, tobacco sponsoring cricket matches, for example, Benson and Hedges, Wills Trophy, all these were focusing, actually, sponsoring cricket matches. For example, now we had just finished the Indian Premier League of cricket matches. In fact, this is not sponsored by tobacco companies, but now it is sponsored by cola companies. Coca-Cola, Pepsi-Cola, that is a parallel. So we need to focus on now this kind of colas, so that which is actually a diet and in fact tobacco, both are addictives. So we are actually moving from one addiction to another addiction. In fact, tobacco also we are not successful, but I think we are moving to the another addiction like diet and colas, etc. That is why we have to be very, very careful in going there. And also, if you look at the companies, advertising for tobacco was too much. Not only cricket matches, movies. In fact, traditionally Indian movies, only the bad people smoke. But nowadays, the good people, the lead roles, even the lead actor also smoke. In fact, there is an impact of tobacco companies on the lead roles by the women lead roles. So which means that is not culturally acceptable to India. But even then, they are actually introducing these kind of things to the population, because the impact of movies to the population, not only the regular movies, but also other movies like television movies, television serials, etc. They are all actually introducing. We need to address them. Then only we will be able to control tobacco further. And tobacco cessation, definitely we go to the entire medical community. For example, each doctor, each general practitioner should ask all the patients, are you using tobacco? Just by asking, probably you can reduce tobacco consumption. Similarly, we have to ask, how much sugar are you eating? How much toffee you are eating? Probably each doctor, each clinician, each health professional should ask everybody about the sugar eating habits, and they should reduce sugar eating. That's all for the time being. I think I will come back if there are any other questions.
Thanks so much, Professor Thangappat. And we are, I think, behind schedule a little bit already. So I'll ask Dr. Farisa a question now. I mean, the best way to prevent DR is to stop people from getting diabetes, but we know that that's not going to happen anytime soon. As a clinician with a lived experience of what it is like to provide eye care to people with diabetes, what are some of the challenges that you're dealing with on a day-to-day basis? And what would be, if you could have a list of a wish list, what would be some of the things that you would like on that list to enable you to see everyone that needs care?
Thank you, Fab. Yep. Well, of course, the best is not to have diabetes, but we know in Malaysia, 1 in every 5 people are actually diabetes. So you can imagine the numbers of population that we have. And my range of patients as young as 20 years of age actually suffering from diabetes type 2. And they have either severe form of non-proliferative condition to the proliferative as well as advanced diabetic eye disease. And all these patients actually have a very different background of education level. And surprisingly, the most challenging situation is to make them understand the seriousness of the condition. You'll be surprised that they will come to my clinic follow-up every time, but they actually did not go for their medical or diabetes follow-up. They always either give a lot of excuses, some of them even not under a proper physician follow-up. Some of them just buy the medication at the pharmacy counter. They didn't go for proper monitoring. They don't take the medication. And it's very sad because as the medical retina specialist, we are giving the anti-VEGF treatment for their diabetic macular edema. So, you know, despite the treatment, the condition is not improving because of their systemic condition is not controlled. So that is one of the most challenging situation that I'm facing in my clinic. And of course, my wish list is to, same like James said, is educate, and educate. We should have more public awareness about this diabetes blindness. We should be more make the public aware about this condition. I'm not sure about other country, but for Malaysia, I think the awareness of diabetic complication, they are focused more on like heart, kidney problem, and other major organs. But the eye complication is always forgotten. They take it for granted. So I'm looking forward for next year to have more cooperation among the companies involved with the care for eye, to have more on the public campaign. The one that James showed, the advertisement, is a short advertisement, but it's very effective and impactful for those who watch it. And at the same time, is for the patient to empower themselves in regards to have the diabetic eye screen. Sad to say that some of our doctors even not aware about referring the patient for eye screen if they have diabetes. So as a patient, if you know that you have diabetes, you should ask your doctor, can you refer me to the ophthalmologist for eye check? Because we have private hospital, we have public hospitals, we also have optometrists in Malaysia that are doing all this screen for the diabetic eye condition. And last but not least is of course the family member engagement. They should aware about whoever in the family member that have this disease, what are the things or the checklist that they have to do to make sure that they don't get blind from diabetes, they don't get nephro problem because of diabetes, or they don't even have a heart attack from the diabetes. Yeah, so I think that's all from me.
Thank you so much, Dr. Farita. I must say, it's refreshing to hear eye health specialists such as yourself and James talking about a public health approach to eye health, and also your message in relation to empowering patients and families really resonates. And incidentally, some of the work that Professor Thakappan was leading in India for diabetes prevention didn't just focus on people at risk of diabetes, but also their families, and empowering them to support the person at risk of diabetes to take best care of their health. So thank you for that. And Michelle, I I think we can't deny, I hope you don't mind me saying that, pharmaceutical companies and the private sector, I guess more broadly, often get a bit of a bad rap. But at the same time, I think, you know, the UN, you know, also recognise that the private sector needs to have a role and take action in areas around promoting, you know, healthy workplaces, improving affordability and access to medicines, and also, which is perhaps most relevant to today's conversation, also reformulating some unhealthy food products. I'd be really keen to hear your views on what you see the role of pharmaceutical companies, and if you want the private sector, I don't mean to put the private sector on your shoulders, but you know, what is their role in the control of diabetes and DI?
Thanks, Fab, and good morning, good afternoon, everyone. Yeah, so I think, I mean, for us, I really want to just focus from a Bayer's perspective and how we feel and react. And I think especially within ophthalmology, we really have been committed to working with the community and with partners such as IAPB and others on the call to really raise the awareness about what diabetes is, how to avoid diabetes, but also how to avoid the complications, as we also take care of multiple complications within diabetes. But I want to take a step back on that just say, actually, our overall mission is health for all and hunger for none. So that's really Bayer's mission and state of mind. And that takes shapes in many ways. So you asked a few different parts in that question. So first, looking at the external space, and if you're going to look to access to medicines, it's really here, I sit in market access, and I can say that we really have taken a revolution in the way that we have operated market access to develop a series of mechanisms that we can then work with governments, payer level, but also in the individual level to make sure that affordability is not an issue for accessibility. In countries like India, Kenya, and Nigeria, we actually just launched some patient access programs that really ensures that we can work with patients to get the therapies that they need. And this is just the beginning as we're really moving towards that more open access to medicines. Now, on a personal level, when we look at health for all and hunger for none, this isn't just being, relevant for the global population, but it's really also relevant for the Bayer family. And here, you cannot be an ambassador to health if you're not really living and breathing it in your own community with your colleagues. And we have a few different programs that I'd just like to highlight too. We have a strong heritage in cardiovascular. And here we do an all year long awareness campaign amongst our colleagues, and it's called Time to Move. And we're always reminding even daily, have you gotten up and moved today? Things like, how about taking the stairs instead of using the elevator? Thinking about healthy dietary choices and just healthy lifestyle choices in general. And this goes all year long to all colleagues. When we look to ophthalmology and specifically, we really here also try to make a large awareness about all eye health conditions, the importance of regular eye exams. And it's not just for, we say, yes, it's for all, but also looking at specific risk populations. So if you look at older people, or if you look at people living with diabetes. Now, of course, we have a large workforce, so there will be inherently people living with diabetes that we're also communicating with. And here we say, not only is it important to have your annual eye exam, but what are ways you can reduce your risk, most importantly, reducing your risk of eye complications too. So it's not saying we're going to prevent everything. It's about understanding how you can reduce it by taking healthy choices. So in a nutshell, I mean, yes, this is something extremely important. I think it is not only an opportunity, but it's a responsibility for private sector and others to look externally and internally. Thanks.
Thank you so much, Michelle, and very much aligned with the messages that Dr. Fariza James and Professor Venkapan have been trying to get across in relation to empowering people to take best care of their own health. I might ask whether, James, you have any thoughts on any of the comments that have been raised by our panel before we move on to questions from the audience.
Sure, we could talk for hours about each of these questions, couldn't we? But disturbed to hear from Professor Venkapan that there are 267 million smokers still in India. I mean, what concerns me is that the tobacco industry, once smoking, in Australia, I mentioned 80% of men smoke, it's now down to for 14%. So the tobacco companies then unloaded all of their tobacco on poorer communities and poorer countries. And I suspect the same thing is going to happen with sugar here. And so it's a real worry that this sort of behaviour is going on. And I know in India recently, I think just this week, we heard that the Indian government is encouraging people to eat more sugar. So this would be an absolute tragedy for the Indian population. So I think we really need to have the same awareness strategies that were in place for tobacco smoking, you know, the banning of ads, and it was great to hear that they're no longer sponsoring sport, but you know, you have Coca-Cola now sponsoring sport, and this is a worry. We need to consider taxing, as we've done in Australia, cigarettes and tobacco products, and also those graphic front of label warnings that we saw certainly in this country, and I'm not sure whether it happens in India, but these are critical things that really need to happen. On Dr. Fariz's, awareness, it's all about awareness, isn't it? And we just need to raise awareness at every opportunity amongst the patients, amongst the general public. And finally, in response to Michelle, great to hear of the awareness programs that Bayer is getting behind. But I think ultimately, one of the most important awareness tools, and certainly in Australia, is free-to-air TV. And if we're saying that type 2 diabetes is more prevalent in poorer communities, then and in poorer communities, they are often using free-to-air TV more than paid channels. And so we need to see, and I've never seen in Australia, I don't think there ever has been a campaign raising awareness of the dangers of excessive sugar consumption. We've certainly seen it for tobacco for many years, but we really do need to see that. And with that ad I showed you of Neil Hansel, that 30-second ad, I reached out to all the pharmaceutical companies who are involved in the diabetes space a couple of years ago, and not one of them offered to help me fund an awareness campaign on free-to-air TV. So, you know, if some of the money can be put into funding awareness strategies through mainstream, I think that would be a fantastic idea. So just a couple of points from me.
Thank you. Thanks so much, James. And Michelle, that was an interesting point that James made at the end there in relation to trying to find support for these kinds of campaigns. I don't know if you have any thoughts on that. Sorry to put you on the spot. I just find it very interesting.
Yeah, no, it isn't interesting, and it's a fair point. And I think what, you know, we as all other stakeholders in this fight against kind of the, you know, trying to prevent diabetes, but also understanding how to manage diabetes and prevent the risk, we are all learning and adapting as we go. And I think that's where we're trying to figure out how best to also reach that patient. So Dr. Mookie makes a very good point to see, you know, what are different mediums and platforms, because it's one thing to raise just the awareness, but you need to empower them to know what to do with that information. And that's what we found with the barometer, is actually they knew it was a risk, but they didn't know how to prevent it. So I think that has to also go a little bit step further to empower them with the tools. So I take his point.
We're almost out of time, and we have lots of questions. Drew, have you been able to keep an eye on the chat box? Are there questions from the audience, pressing questions from the audience?
I had been able to keep an eye on it. Thank you very much, Fab, and thank you very much to James, who has been answering questions as we go. But I do have a very important question here. It reads, James, thank you for using your important status to driving attention to this in Australia and around the world. In your experience with advocating with government, what are you seeing as the biggest challenge to governments making policy change and to invest in preventative strategies to combat this epidemic?
Thanks, Drew, and thanks for the question, Amanda. I was literally just typing it as we speak. But yeah, so the very loud voices that are constantly in the government's ear from big sugar, basically from industry. That's a huge problem with any public health. It was the same problem with big tobacco. Also, the dietary guidelines, which inform what's eaten broadly in our society, there are significant vested interests and conflicts of interest in creating those guidelines, which in Australia, at least, we're about to review our guidelines, and anyone or any organisation who has conflicts of interest should not be included in that review process or in setting guidelines which inform national policy. But interestingly, in Australia, you know, this is, tobacco is one thing. This is huge. This is sugarcane farmers. This is the sugar industry. This is the processed food industry. This is the the beverages industry, the cereal and grain industry. It's huge. So what we need to do is, sorry, I just had a mental block there. Yeah, so these are constantly in the ear of government and confounding the literature. And so what we need to do is, yeah, so basically this for the government, and I'm sure it's in every country, means jobs, a significant amount of jobs in each of those industries. It means revenue that's generated from each of those industries, but also perhaps even more importantly, votes. So with our two major parties, they're what we call marginal seats, and particularly marginal seats in sugarcane growing areas. So they're very hesitant to actually put potential voters off in those sort of marginal seats by, for example, introducing a sugar tax, which might impact on sugarcane farmers, although it's not been shown to do that in a number of countries. So those are the other things that the government has very much in mind and makes it difficult for them to manoeuvre through this space.
Thank you, James. We have been talking about diabetes and DR, and of course we can't ignore what's happening in the world at the moment with the pandemic. So what I would like to do for the next 5 to 10 minutes or so is just engage the panel a little bit in a conversation around the impact of COVID-19 on the kinds of topics that we have been talking about. So Professor Thangappan, we've already talked about how managing diabetes is the best thing that we can do to prevent DR. The pandemic presents a whole new set of challenges. In your experience as a medical doctor and someone that's been working with patients with diabetes, what can we do to control the risk factors for the development of DR during the COVID-19 pandemic when people are having difficulty seeing doctors?
So I think, first of all, let's talk about the control rates of diabetes in India before the COVID. In fact, this is one of the poorest controlled rates we have in India. You know, Kerala probably is the most advanced state in India, within India, the most advanced in epidemiological and demographic transition, and also health systems. So in Kerala, we have almost similar to Malaysia, we have 20% adults have diabetes. And the control rate is less than 15%. Control rate means less than 126 milligram fasting blood glucose. So that is very, 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 very small. For example, in all other health indicators, Kerala is comparable to the East Europe or some of the European countries, where the control rates are much, much higher, maybe close to 60%. But where we are is only 15%, less than 15. And this uncontrolled diabetes and also hypertension leads to lots of dialysis, as already mentioned in the plenary speech. And we have one of the highest dialysis centers in India within Kerala, a large number of dialysis patients because all of them end up in dialysis. So this is a very, very poor condition in Kerala and overall India. Of course, in other parts of India, it's much lower than Kerala. So what I'm saying is after COVID, what happened is there's no access. No, people, particularly above the age of 65 and 60, they were asked to be within the home. In fact, as an expert panel member of the Indian Council of Medical Research on Diabetes, we had some activities related to COVID-19 and diabetes. And we are actually preparing a guideline for diabetes management during COVID. For example, which type of patients should be allowed teleconsultation, telemedicine, etc., and which patients directly should go and see the doctor or the healthcare provider. And we are actually developing that. And unfortunately, what is currently happening is the internet penetration and the smartphone penetration is not that high. Of course, particularly if you go to the rural areas, that is a big challenge for India. And the internet bandwidth, that is also a big challenge. That is why internet facility, telephone consultation, etc., is not that easy in India. It's a huge country, and we have 75 million diabetes patients in India, almost 3 times the entire Australian population. Huge diabetes. And the access is very poor. Access to medication is very poor because the regular medication is not there. The distribution is a big problem. And 50% not aware of the diabetes, 50% are not on treatment, and those who are on treatment are not regular. These are one of the major problems. And the COVID-19 has exacerbated all these areas of diabetes control. Thank you.
Absolutely, President. I think you raise a really, really important pain point, if you will, which is the intersection between diabetes, age, and the interaction between those two factors and the impact that they have on accessing diabetes services at the best of time, but in particular during the pandemic, and the fact that they don't even have access to the technology that's necessary. So that's a very important point. Dr. Farisa, I think arguably, I hope you'll agree with me that, I mean, I'm biased, but the eye healthcare sector has been particularly impacted because it's particularly difficult to have interaction with patients when you have to be so close to the patient during the pandemic. I came across this study which said in Europe, in the first month after the pandemic, up to 87, on average, I should say, 87% of services contracted. So it was almost a complete shutdown of eye care services. There were some questions in the chat box about frequency of screening, and we know that people with diabetes should have their eyes screened at least once a year, if not more often, when they do have DR. I mean, I don't know if you have an answer, but how can we manage this during the pandemic? Is it possible to think about stratification of screening by risk, or can we do remote retinal screening? Is that even a possibility?
Okay, thank you, Feb. Actually, this is a very interesting question. We has been, in our setting also has been discussed about this condition, and it's not easy to come out with the solution. So for Malaysia, most of our health centers, actually, they have this fundus camera, whereby it be manned by our paramedics who've been trained. So this health center, actually, they have no ophthalmologists. So I think what we need to do is to enhance our competency of these graders to ensure that they are able to do a proper grading of the fundus, and also if they have any issues, they can always communicate with us easily with the teleconferencing. The other thing that we are actually in the process of doing, actually this come even before COVID-19, is to establish our primary eye care services in the health center. So this primary eye care services is to be manned by the optometrists. We are not planning to have ophthalmologists there. So it will be managed by our clinical optometrists. They will be like the primary eye care providers. They should be able to do the screening for diabetes, or even to tackle the simple cases of eye condition. And if they have any doubt, they can easily reach out with through the teleconference with the ophthalmologist of the we will have like a mapping whereby certain health clinic, they will go to certain hospital. I think there's a lot of discussion talk about AI for virtual teleconferencing, but for ophthalmology, I think it's a bit challenging because you know, we need the slit lamp, we need to see the detail of the eye, not just asking how's your eye, is it red, is it pain, all that. So it's not as simple as that. So until we can come out with a certain definite solution in regards to virtual consultation for ophthalmology cases, I think we still have to see the patient, but of course we must ensure the appointment, the schedule is given accordingly. Now I think we still follow minimum of yearly appointment for our no diabetic retinopathy cases, but I think I agree with James, we should go for every 2 years, especially for those patients who are have a very good diabetic control, and we know that their previous eye findings has no evidence of diabetic retinopathy. So this is where we need to empower our patient, we need to educate them in regards to their disease.
Thank you, Dr. Farisa. I think that speaks to a point that maybe it's a silver lining in everything that we've been experiencing, that the pandemic is actually pushing us to think about efficiencies in a way that's going to be useful well beyond the pandemic in itself. And of course, what you were talking about in relation to task shifting, it's definitely the direction that at least the DR sector is moving in terms of identifying people with the condition. So thank you. I feel like we've talked about prevention, screening, and Michelle, from a treatment point of view, we've seen what the pandemic has done to the development of the vaccine. It feels like we're moving at an incredibly fast pace. I'd be interested to hear your thoughts on whether the pandemic has had any impact on the pharmaceutical industry beyond the vaccine in terms of provision of drugs, and in particular for ophthalmologists and DRs.
Yeah, no, thank you, and I really appreciate the previous comments, because this has been a fast-moving navigation that we really have to be on our feet, thinking light, thinking fast, working together, and really solution-oriented. So it has really accelerated this telehealth medicine, but also put a lot of people at risk of irreversible vision loss. But everyone's doing the best they can in a complex situation. And we see now that new vaccines in 2021 are becoming a more reality, and this is wonderful and welcome news. But with it will also bring future challenges as well as we navigate that new space. So COVID-19 impacted so many sectors, and pharmaceutical was not spared. But I think it also, as you mentioned, with the new vaccines being developed, it also highlighted the role that pharma can play and the benefit that we can bring to societies. So I think that was important for pharmaceutical to see this advancement. When we're looking to Bayer ophthalmology specifically, yeah, I mean, during the first wave, we really saw immediate lockdown. We had calls with our retinal experts to see the case, and over 50% of their patients are proactively canceling appointments. Now, this is understandable, though, because if you look at people who need regular anti-VEGF treatment, you're looking at either an older population, so 80s plus with age-related macular degeneration, or people living with diabetes with diabetic macular edema. So this is the higher risk group for COVID-19. But at the same time, these people are also not only concerned about COVID, they were concerned about losing vision. And in certain cases with AMD, it could be irreversible. So I think we got together with the ophthalmology community, the retinal experts, quickly within days to see what could be done and how we can support the community. And as mentioned, there was actually guidelines on how, guidance, not guidelines, but guidance on how to adapt your practice based on the expert's opinion, which was published in Graves Journal. And then we also developed patient-facing resources, because the figures you mentioned, yes, people were, those 50% that were canceling, there was a research done in the UK, 70% of them would have gone to clinic if they knew what safety measures were put in place. It's around 70%. So we looked at facing, how do we fill both those gaps and make sure they understand the safety measures that the clinics are putting, ensuring staff patient safety, and so they can feel more at ease to get that sight-saving treatment. So that's one aspect. The other aspect that you asked for around is the future of therapies and our supply chain. So Bayer went right into implementing safety and procedural measures to ensure that our supply chain was maintained, and thankfully, and we were successful in that with no hiccups. Not only that, did we actually launched a new device within our ophthalmology successfully during the pandemic. And when we're looking to our future trials, we actually have just started 2 trials looking at extended duration, where we're hoping that we can get a majority of our patients to only receiving treatments 3 to 4 times a year, because we understand that duration of therapy needs to be extended. This is a critical unmet need. So even within the situation, we still have been able to drive forward with that.
Wonderful. I'm really pleased to hear that. Definitely, speaking from my experience with the programs that we implement through the Federal Arts Foundation, adherence to treatment is always a challenge, and the frequency of the injections is a problem. So having a way to work around that would be amazing. And the point you were making in relation to the fact that the patients who are at higher risk of COVID-19 are also the ones that are at highest risk of vision loss speaks to the point that Professor Takapan was making before as well. So thank you. This brings us very close to the end of the session. Apologies for being late. I see that James has been very proactive in answering questions in the chat box. So I feel like that gets me off the hook in terms of taking up more time with audience questions. I just wanted to say, James, I'm going to throw it back to you, put you on the spot again. Do you have any reflections on what any of the our panelists just said? Well, maybe I think you're on mute, James. Sorry.
Yeah, good.
Sorry about that. Yeah, what we do know in the current pandemic situation is that we're 12 times more likely to die of COVID-19 if we have chronic diseases such as type 2 diabetes. So we're talking about controlling the risk factors for diabetic retinopathy. It's really about controlling the risk factors for type 2 diabetes. So once again, an awareness campaign to encourage healthy eating and improve our metabolic health is really critical here. And the second question, I think, in terms of stratifying risk of patients with diabetic retinopathy, there is a group out of Scandinavia, I think from Iceland, called Retina Risk. And I've just put it in the chat line there, the website. And they have an app which people can download to their smartphones, which stratify their risk of getting diabetic retinopathy, and also then allowing them to work out how often they need to have their eyes checked. So that's something that is probably worth having a look at. I've certainly shared it with colleagues, retinal colleagues in all of the countries that Sight for All was functioning, and they're finding it very useful and with their patients. So I think it's quite useful for everyone to know about that. And the final question to Michelle, I think the interesting thing about COVID-19 is that it's exposed areas in our health system and our personal well-being which have been neglected and made us more vulnerable to the virus. But also really importantly, that vaccines are likely to have some limitations in their effectiveness and impact if significant proportions of the population remain obese or metabolically unhealthy. So once again, it comes back to metabolic health and raising awareness of the dangers of our current modern diet, that we really need to have a system change, which is not just one strategy, but multiple strategies to raise awareness and to reduce the predatory marketing and sales tactic of industry. It's just enormous, and it's going to take a long, long time, but it's time to start, I think.
Thank you so much, James. Sorry, go ahead, Michelle.
Oh no, I was going to say, I mean, this is not a singular kind of issue, right? This is something that we need to really make and push and make sure that we're all responsible, and all of private sector and all of the, that goes beyond pharma. I think we need to make sure that all industry within the private sector need to see this and the role they could play and as well. So I do take Dr. Muki's point that we have to come together as a full community and say that, this is detrimental. And it's detrimental to children and the long-term health. And so I think working with governments and the UN sector's call and welcoming the private sector to come and play a role, I think is a great first step forward.
Thank you. And I want to say a big thank you to all the panelists for giving up their time today, for taking the time to consider the questions so carefully, and for giving us really, really, really useful insights. I hope you'll all agree with me. It's been a really, really interesting session. And I see there's quite a few participants still on, so thank you for staying back even though we've run over time. And a big thank you to Dr. Muki for your time as well, and for your insights. I want to give you an opportunity, just if you have a take-home message, 10 seconds that you'd like people to leave the session with, what would that be?
Okay, so as ophthalmologists, people working in the blindness space, I was just dealing with the end-stage complications of a dietary disease, and not in 30 years really until recently considering the underlying cause of sugar and the highly processed foods that we're eating. So I think it's important for all of us working in this space to be conscious of this, to become advocates as well, not just simply just deal with these complications. We should be out there campaigning to reduce this terrible situation that we're currently in. So I would encourage that, and also make everyone aware, your patients aware, that they have the opportunity to put their disease into remission. So really important information as well. Thank you for the opportunity again, and the IAPB team.
Thank you. No, thank you. Just to let everyone know, the session will be available. It's being recorded, so it will be made available. My understanding is that it will be on the Facebook page and YouTube channel as well, so you can access it through there or share it through it. And also next week, there's the Gender Work Group who will hold a session on Thursday at 8 AM GMT. It's shaping up to be another really good session, so I would encourage you to attend that as well if you can. Thank you all. Thank you to the IAPB team who's made this possible, and enjoy the rest of your day, evening, afternoon, whatever it might be.
Thank you.
Thank you.
Thank you very much.
Bye-bye.
Thank you so much.